Good afternoon, everybody. Welcome to IPC Masterclass. We see 82 professionals already online. I believe there are more to join. We'll start now. Before we start and hand over to Dr. Rangareddy, a couple of announcement, housekeeping announcement, what we call it. Number one, uh, just to inform you, whoever is not speaking right now, please keep your microphone off. Uh, Number two, you see the chat box, and I saw many of you have already put questions and comments and compliments, messages in the chat box. Please keep on doing that. You can ask questions in the chat box. Number three, somebody want to speak directly to the whole group audience. That is also allowed. How to do that? Simply, you see there is a hand icon, speak is written there. You need to click that. I will get a notification about that and I will activate that, and then you will be able to speak to the whole group. You will be able to speak to the speaker. Fourth thing is that sometimes maybe because of internet or any reason, the internet speed is slow. The video will go off, but the audio will be always there. And the fifth and the last thing is that in case of any disruption, you will be again joined automatically to this room. So automatically you will be for a moment, maybe few 5-6 seconds, you might be out of the room, but again you will be automatically joining in the room. So don't be worried about those minutes. With this few housekeeping announcement, I see the number of people also reaching 100 who are in the call. Just to share that there are 350 people joined in this call, and 100 people almost already inside this room. With these comments, let us start the session. Handing over to Dr. Rangareddy, the president of IFCAI.
Namaste. I am happy to see you all in this web class. This masterclass series on outbreaks, epidemics, and pandemics is a joint effort by Infection Control Academy of India, Indian Institute of Public Health, and University of Hyderabad. As many people have already posted, I think it has really been an apt time in order to talk about these issues in the current scenario, which is keeping all of us very busy and also worried. The ongoing pandemic and its catastrophic consequences has laid bare the fragility of our healthcare systems worldwide. This has also subjected populations worldwide to immense socio-economic and behavioral effects and has impacted our world like never before. The contextual generation has never seen or been exposed to something like this in its lifetime so far. The scientific and academic communities caught unawares by the rapid onset, progression of current pandemic and consequences of this, as well as lack of preparedness. Well-trained and informed healthcare human resources, as we all know, is key to handling healthcare emergencies of current times, and also currently lacking of them is precipitating the current situation. So, today, while we are going to talk about the epidemiology in the context of COVID-19, We have set a few objectives for this 5 lecture series. As you probably would see in your slide, the first and foremost objective is that to sensitize and improve the capacity of stakeholders. That is, all those our colleagues who are in the forefront of fighting the current pandemic. Second objective is to give a quick refresher on terminology and concepts of epidemiology for all our infection prevention and control practices in times of outbreaks, epidemics, and pandemics. The third objective is to update knowledge of all stakeholders on contagious diseases management and improve access to tools, expert advice, best practices, and resources. The fourth objective is to allay the myths, misconceptions, and sometimes even lack of basic understanding of genesis and progression of this pandemic. And the last one is to encourage all our colleagues and their efforts to set up and institutionalize structured surveillance modalities so that we can effectively deal with the future epidemics, pandemics, and also the outbreaks. As I told in the beginning itself, this series is made possible with the kind collaboration of University of Hyderabad and Indian Institute of Public Health Hyderabad. And it is also need to be mentioned that Sanmed Healthcare, who has thought about having this masterclass, IPC masterclass, which has made uh, this particular effort even worthier, and we really commend them for making this happen for all our infection preventionists who are at the forefront of fighting current pandemic. Sanmed's idea of IPC masterclass, I am sure, is going to make a lot of difference to the current fight. And now coming specifically to the today's topic, it is going to be the first as of the 5 series, and today it is going to be about revisiting basics in terms of current global healthcare crisis. This particular lecture, which is the first of the 5, is going to be presented by Dr. Samiksha, who is currently working as additional professor at Indian Institute of Public Health Hyderabad. As you all know, IIPH Hyderabad is part of PHFI. She is a PhD in epidemiology and a population health from London School of Hygiene and Tropical Medicine, United Kingdom. She has done her MBBS and MD from Delhi. Her work includes research and evaluation of programs in maternal, child health, HIV, and health systems. And she has also worked with various national and international organizations such as NACO, USAID, UNICEF, and CDC. So, without further adding much, let me now hand over to Dr. Samiksha, who is an able and practicing epidemiologist, so that she can refresh us with all the basics of epidemiology. Dr. Samiksha, over to you.
Right. Thank you, sir. Thank you for the introduction and having us started with a wonderful webinar series. I hope we will be able to pass on a lot of scientific understanding as well as build the evidence towards the general understanding of how the pandemic is being dealt with and what more is required in the future. Just give me a second to start my presentation. Okay, just a second. Right. So hello everyone. I hope you can see the slides. Can anybody confirm if it is visible?
Yes, Dr. Samiksha, it is visible.
Right. Perfect. Thank you. Okay. So, uh, Ramdas ji, I can hear my echo. Is there some problem in the system?
Yeah, now there's no echo. You can go
Okay.
ahead.
Thank you.
And your visual is not your thing. I think you have to turn on your video. Yeah, that's fine.
Right. Sure. Okay. Great. Thank you. Welcome everyone. And today we will start with the basics of epidemics and pandemics. And it will be epidemiology oriented. And I'll try and connect some from history to epidemiology to the current situation. And we'll leave you there where the next speakers will pick it up. So it will be more about the basic science. So first and foremost, what is outbreak, what is epidemic, and what is pandemic? So as per the definitions, outbreak is any increase in the occurrence of the number of cases of a disease under consideration above what is normally expected in a population in a confined area. So the later part of the definition is very important. Outbreak is generally in a small geographic area, in a confined area, and the number of cases are more than expected normally. So what does that mean? That if you have a malaria case or malaria outbreak, when will I say it as malaria outbreak? When I have malaria cases much more than they used to be in the previous time, in the same season, in the same city, then only I can say it as an outbreak. Whereas there can be other diseases such as polio. So we are at a stage, you know, that polio is eradicated from India, but even a single case, if detected, will be counted as outbreak, right? So it depends on disease to disease, and it depends on how much of the disease already persists in the community. So there is a no hard and fast rule on when will you call it outbreak. It is to do with more than what is normally expected in a given confined area. So that's what we need to remember. Outbreaks, mostly how we know is as infectious disease outbreaks, but there can be outbreaks due to chemical exposures. Uh, for example, if there is some kind of spraying happen and the population suddenly reacts to that spray in form of exposure or skin diseases, suddenly you may say a lot of skin diseases patients coming up in the hospitals. So chemicals can also introduce sudden outbreak, limited to just infectious diseases. Now then, what is epidemic? Epidemic is also a sudden increase in the number of cases above the normally expected numbers, but in a larger population and a larger region. And the scale of it is also much more than the outbreak, in both in terms of numbers and the coverage area or the population in consideration. Then these epidemics, so what is a pandemic then? Then pandemic is something when an epidemic spreads beyond the geographic region, then it is called pandemic. So conventionally, if the pandemic is called pandemic when the epidemics cross borders and reaches to some other countries. The COVID example, 19 is one of those examples. We call it pandemic because it has crossed the international borders and affected across the world. You may know that while it was in China, it was not called pandemic. It was still limited to the Wuhan region. It was called epidemic. Once it started spreading across the world, it's when WHO declared it as pandemic. So we have a long history of pandemics. It's not that epidemic and pandemics are new. In this graph or infograph, you can see it's a pictorial presentation of number of deaths in millions and over a period of time. So these are the farthest ones, somewhere around 534 AD, and these are the recent ones, which is in 2020 right now, which is coronavirus. And the size of these balls is trying to show these are infectious diseases, and the number of deaths they have caused. So the bigger the size, the more number of deaths they have caused. So largest pandemics in our history have been bubonic plague, which took a toll of around estimated 200 million. It was around 1347 and 1351, lasted for a long period of time. Then smallpox and Spanish flu in 1918 and 91. These have been the largest pandemics if we consider the number of deaths they would have caused. Amongst the recent pandemics in the last century, we have had Asian flu, Hong Kong flu, HIV/AIDS. HIV/AIDS is also considered as pandemic because it spread across the countries, and it is one pandemic which is slow to spread, but it continues to spread. It affects large populations, and that's why it is also considered as pandemic. It is still ongoing, and it has also taken a large number of deaths, which can be attributed to HIV/AIDS disease. Last big epidemic or pandemic, sorry, which took a lot of deaths from across the world was in 2009 and 2010, which was swine flu pandemic. You will notice after that there have been small pandemics like SARS, MERS, novel COVID-19 virus causing COVID-19 disease. Last few pandemics have been mainly due to viruses, influenza viruses, H1N1, and also the family of coronaviruses. These particular ones, SARS, MERS, and COVID-19, all three of them have been due to a family of viruses called coronaviruses. And this is what raises a concern that this airborne infection is something in front of which the world suddenly feels weak. So this is some examples of the pandemics from the past. So this is to show geographically that what pandemic really means and look like. So if you see on the left hand side, so this one is for swine flu. So these many countries were affected by swine flu, and the darker the color, the more number of people affected in that country. And in the corner right, you can see that we have the recent map for COVID-19. It is ongoing. We have no idea how it would look like in the coming days to come. But you can clearly see that it also affects almost every country in the world. Epidemics. By definition, you may remember that epidemics were localized. They may not necessarily cross geographic borders. So this map shows that these many epidemics have been reported time and again from across the world. Good thing is they have stayed and been restricted in those small geographies and have not spread as pandemics across the world. So when we have so many pandemics to list, we have much more epidemics to list from across the world. This is to show quickly that in last 21st century that we have had lot of epidemics which are in orange and pandemics which is H1N1 influenza, which is your swine flu pandemic. In response to these pandemics, what happened was that world realized with a lot of globalization. Now every infection, like every commodity moves from one place to another, infections also very quickly move from one place to another. And it is not possible at all to deal with these epidemics and pandemics unless all the countries come together. And there have to be some essential steps to be taken towards preparedness of it. So in last 2 decades, internationally, big steps have been taken. And because these have been mostly infectious diseases, the one of the steps which was taken is to establish an alliance for vaccines. Gavi, it is called Gavi, the Vaccine Alliance. They do a lot of research and promote vaccination use for prevention of infectious diseases, especially of those which have potential to turn into epidemics and pandemics. Then they also set up another alliance or a network, which is called the Global Outbreak Alert and Response Network. This is important. What this network does is that it makes it compulsory for the partner countries to notify any outbreak in their region. Remember that all pandemics start from outbreaks. It always starts from small thing, not contained, it grows into epidemic, not contained, it grows into pandemic. And this network notifies these outbreaks as soon as possible so that everybody is on alert and kind of keeps a watch on how these outbreaks are spreading or contained. Well, that was not enough because just notifying does not mean that the countries come together towards working in containing it. So in 2005, as a response, they came up with the international health regulations. Around 150 plus countries are signatory in these regulations, and they have a legal binding to report and support in all kind of epidemic and pandemic control measures. So this brings all these countries which you talk about into legal ambit of being responsive and responsible for the pandemics and epidemics that are happening across the world. After that, in 2009, as I said, in 2009 we had swine flu pandemic, and we saw a lot of influenza based pandemics occurring, and these influenza based pandemics were taking a lot of deaths. They spread quickly, they spread very fast, and our systems and community do not have that much preparedness. So globally, they developed a pandemic influenza preparedness framework, which is called PIP, sorry. This basically is a framework to help countries to prepare beforehand for such kind of pandemics if they come, how to deal with it. The truth is, in near future, we expect more such pandemics, and the scare for influenza and coronavirus pandemics has been there since we have known our history of pandemics. So it's not new. It was not that we were not aware that such kind of a thing can anytime happen. But the problem is probably we are not still as much prepared as we should be to be able to control these pandemics. So this is just repeating the two important steps which have been taken in last 2 decades in this century. One is international health regulations. 196 countries across the globe have agreed to implement the international health regulations, and the pandemic influenza preparedness plan, which was launched in 2011. Both of them have been recently revised as well. Now coming to the science of it, the epidemiology of it, we realize that most of these major pandemics and epidemics are infectious diseases. And how they spread? They can spread from human to human, like smallpox. Smallpox did not have any animal host, or it can spread from animal to human. Plague started from animals. Even COVID-19 theory is that it started from bats and then spread to humans. It can spread from vectors to humans. It can be affected through environment or hospital-acquired infections. Even within hospitals, there can be small outbreaks and epidemics because of hospital-acquired infections. Waterborne diseases, cholera, that can be an environmental factor, like water got contaminated and then it spread into a infection, right? So, and epidemics and pandemics are not restricted to humans only, because we respond to human epidemics and pandemics, but epidemics can spread in animals too, right? So swine flu was, in fact, it spread in the birds first, and from that epidemic it came to humans and it spread into humans, and from it turned into human to human transmission and become a epidemic amongst humans. So what happens? Why do we have epidemics? We have a lot of bacteria and viruses already in the system, but why do we suddenly see epidemics coming up? So it is possible that the epidemic is due to a recent increase in amount or virulence of the agent. Suddenly, a existing virus becomes, or due to some mutation, is more infective, right? It already existed in the system, but now the mutant form of it is more infective. Okay, or it is possible that is a new virus being introduced, or a new bacteria being introduced, or a new agent has been introduced in the population which never existed before. HIV was such example. HIV virus never existed before. It was a new kind of a virus which was noted in humans, and that led to a pandemic, slow growing pandemic, but yes, pandemic. Or there is an enhanced mode of transmission. Example could be malaria, dengue. You have seen seasonal outbreaks and seasonal epidemics happening. Why? Because the malaria parasite may still be there in the system, but the mosquitoes breed more in a specific season. And because the mosquitoes are breeding more, there is an enhanced mode of transmission of the parasite and spread it to humans. So just increased mode of transmission. Globalization. Globalization cannot be taken as a literal example, but yes, why pandemic spread so fast these days? Because because of the globalization, we have easy access to transports across the world, and this has influenced the speed in which the epidemics spread or the outbreaks spread across regions. Other reason could be that something might be changing in the host as such, something might be changing in humans as such, which makes them more susceptible to certain infections, or uh, chronic renal diseases. When immunity goes down, they may be prone to certain infections. So the change in the host ability to deal with the infection may change, and you may see epidemics coming out. Okay, and there can be many other factors in which the exposure happens, which could lead to epidemic. Like we may think that the exposure happens just by waterborne, but it's later on it may be realized that it may spread from person to person also by touch. So some kind of change in the exposure mechanism can also lead to epidemics, sudden epidemics. So, what is an outbreak? What is an epidemic like? So, we will be talking about epidemic. I'll be using the term epidemic more because it is something between the outbreak and pandemic, right? Although everything starts from outbreak, but it doesn't take much time from an outbreak to convert into an epidemic, and a sustained epidemic, an extended epidemic can also become a pandemic. So, I'll be using the term epidemic, but the concepts will apply for three of them. Okay, so what generally happens when epidemic occurs? There's a whole phase in which epidemic progresses. So there is an anticipation. You know there are certain new viruses coming. Like as I said, we always anticipated another influenza kind of pandemic or epidemic to happen. So you have an anticipation phase. You know what kind of viruses may be available. And when you see that new cases started to come, right? That's where you call it as early detection. And mostly the early detection happens in clinics and hospitals when you see a different kind of cases coming up, or the same kind of a disease, but lot of them coming up together in a shorter span of time. So there is a sudden increase in the number of cases. That's the time when the epidemic can be detected early, and it has not yet been in a local transmission phase. But if it continues to progress, if you do not contain them, then it can go into a localized transmission phase. So sporadically, you will see cases coming up, and in a very few people, it would be spreading. That is still a phase where you can contain the epidemic. Okay, so local transmission is spreading, but you still have opportunity to do containment. But if it goes beyond, it, it amplifies it. So that's a phase of amplification. There we do not have much control then. What all we do is try to control the disease spreading from spreading as much as possible, and try to reduce or minimize the effects of epidemics on health, on economics, on mental health, on all other parts of societal impacts which any epidemic or pandemic creates, or uh, uh, on the public, on the population as a whole. And lastly, what happens is that once the amplification has happened, as per science, most of the time you can understand that if everybody has got infected, obviously the disease will slow down by itself. Or if we acquire herd immunity, that once I've got an infection, I'll not get the disease again. Or due to herd immunity, slowly you will see the number of new cases will start coming to reduce. So there's reduced transmission. That is the phase where if you want to do any response, and if we have effective means of controlling or eliminating the agent, then we can look at elimination or eradication of a disease. The classical example of this phase of whole epidemic and its response is smallpox. We had smallpox pandemic, followed by local transmission. It was a smallpox outbreak, spread into local transmission, then it amplified, it became a pandemic, and after a period of time, there was reduced transmission of smallpox. Smallpox still persisted, but it became kind of an endemic disease. That means it persisted in the population for a longer duration. In the meantime, we identified a vaccine for it, a very good vaccine, which was highly effective. And then we, as a whole, across the world, we had a strategy to eliminate and eradicate smallpox by mass vaccination of the population. So that is a classical example of the phases in which it progresses, any outbreak or any epidemic progresses. Now you may see these arrows which I have pointed out. The best time when we can control any outbreak or epidemic is at the early detection phase before it even goes beyond local transmission. That's the best time. So at that moment of time, we do outbreak investigation and containment. If it spreads into local transmission, we may still have option of controlling it from becoming a pandemic if we appropriately do epidemic management and proper containment. Beyond that, we will just have measures to control and mitigate the after effects and the secondary effects of the epidemic. So these two arrows are very important. And when we go further, or even in this webinar series, you will be able to relate to where we stand, India stands in terms of COVID-19 epidemic, where it stands and why and what steps have been taken. So this would be useful. Before I move on, I would like to take a break, and I would like to just put some questions for the audience to respond to that will reflect on your slides on your screens as a poll. So I'll put two questions for now. I'll ask all the participants to respond to it. Please. I hope this is visible.
Yeah, this poll is live now.
Right.
People are responding that.
So I can continue, or shall I wait for them to respond?
Just wait for a few seconds.
Okay.
And then we can continue.
Right. I would request everyone to respond to it. Please, let's take 30 seconds to respond to it. Thank you. I guess this was a simple one. I hope everybody would have got it right.
98% people responded well, I think.
Right. Okay. Thank you very much. I'll have Another one for you, please. Let's give 30 seconds to this one. Great. I guess people are still responding, and thank you for your participation. It feels very appreciating and nice that when people respond to it, we also feel that we are connecting to you. Okay, it's time to close the poll. Thank you. So I would first give you the answers. The first one is pandemic. As I've told, if the outbreak spreads across borders, across countries, it's called pandemic. It involves bigger geographic regions. And yes, all these three disease epidemics, SARS, MERS, COVID-19, they have been caused by coronavirus family of viruses. Okay, great. Whoever answered correct, thank you. And whoever did not, I guess they got the right answers now. So now I'll move forward. Okay, so as I said, that the first thing, the only chance we have to control the outbreak and epidemic is to detect it early, invest into it, what it is, what can be done to control it, and quickly try to control it. So the epidemic investigation is a scientific process, and it has certain steps which have to be followed. I will run you through all these steps, and this is essential because for any new disease that comes or a existing disease reemerges, first we need to understand the phenomena, what is happening before we can take any action, right? So the first thing, how it starts is that some doctor or lab will report that there are a lot of cases being coming to the OPD, a lot of cases of, let's say, coronavirus sample is coming to my lab, and they will notify it to the designated authorities. We feel that there is unusual increase in some cases. So the designated authorities then have a responsibility to do investigation into such kind of notifications or reports. The first step then becomes is prepare a team and prepare for the field work. So you first establish a team, and depending on what kind of disease is being reported, you bring in people. So if it is like a disease which is coronavirus disease, COVID-19, you would like to build a team of medical doctors, virologists, right? And public health specialist, microbiologist, right? So a team of such people who would be able to address issues with this kind of a disease. Imagine if it is swine flu. If it is swine flu, we know it is spread through poultry. So you may want to keep someone from poultry also. If it is some disease, anthrax or something which spreads through animals and may have come to humans through animals, you would then need an expert who is a animal husbandry expert or zoonotic disease expert. So what constitutes a team also depends on what kind of a disease is being reported. And sample collection. Again, what kind of disease is being reported will give you some idea of what kind of a sample collection would be required, what media. So you have to prepare for all of this before you go to the field, right? Then when you go to the field, first thing you have to see is there really an outbreak or was it a rumor? So you check the records of these people who have notified such increase of cases. And if you see, yes, there is a similar kind of case reported in large numbers in a smaller duration of time in unexpected numbers compared to previous season, previous years, then you say, yes, it is an outbreak. But even then, the next step comes is what is the diagnosis? Because people who are reporting may not have the clear diagnosis. They must be reporting on syndromic basis, or if it is reported by lab, definitely there will be a specific lab diagnosis. But many a times it just comes as rumors, or diarrhea reported, or ARI reported, or pneumonia reported, or lot of fever cases reported. So you don't really know what specific diagnosis it is. So then you have to do verify the diagnosis, what it would be by clinical examination. So you can have a clinical diagnosis, like pneumonia can be clinical diagnosis. But then you confirm it with lab diagnosis, what is causing this pneumonia, right? So identifying the virus or bacteria in it. So these two things would be required to make your diagnosis. Now you know it is outbreak, you know what is causing this outbreak, then you have to construct a working case definition. Why I'm saying working case definition? Because we have made a clinical diagnosis above. Why do we need a working case definition? Because when these outbreaks happen and when these epidemics happen, the problem is that we do not have enough time to detect and test everyone. We want to make a definition which is realistic at that moment of time, which we can use to quickly identify the potential or probable cases who would further need clinical testing and lab diagnosis. So such definitions can be in form of syndromic definitions, also including the high risk exposure. I'll come to detail of this when I'll be telling you, describing you the definition of COVID-19. So generally just remember that if it is one or two case, you have a different diagnosis, which is confirmatory diagnosis. But when it is in terms of outbreak, you have to make a suspect diagnosis so that you know who are the suspected cases who should be further tested, or probable diagnosis. Probable diagnosis is that they may have symptoms. You are waiting for the lab diagnosis to come before you can say it is a confirmed case. And the confirmed diagnosis. These three diagnoses are very important to be able to identify cases as early as possible. And the suspected diagnosis helps even the field worker to identify the suspected case and refer them in time to the health system for further diagnosis, right? So that's why constructing a case definition for the given scenario in the given time becomes important. After that, once you have that definition which you have developed, then you do line listing of cases. You want to know how many of the cases really exist in this population. Whoever reported, they reported just few cases, right? So you want to see how many of them really exist, and what is the relationship, what is the distribution of this epidemic in terms of time, place, and person. We'll be touching on each of these as we go further, and then try to describe who got exposed, who got diseased, what kind of people got diseased, what kind of fatality rates we have. Can we establish some kind of association, like older people are dying more, or younger people are getting more disease, or people living in certain area had more disease compared to people living out of the village. So doing some kind of a descriptive analysis then gives you an association building up. In next steps, what we do is once we establish there is some relationship between some factors, then that is called a hypothesis. Then we develop a hypothesis. Like the disease is more prevalent in certain place or in certain group of people, or they may have a potential exposure. So you may have such kind of questions or statements coming out of your descriptive analysis. And then the statement, the answer to such kind of questions becomes your hypothesis. Next step is epidemiologically to test that hypothesis. This is what you have just generated. No, it's science, it's epidemiology. Just your opinion will not work into making a whole containment plan or make everybody, the whole system to work towards it. So you have to test your hypothesis. I'll not go into it how to do it. It is a different epidemiology in it, but you test your hypothesis. If your hypothesis proves right, then you have to continue working on it and scientifically identify what kind of control measures are required. I must say that you don't wait for control measures to start till you do all this exercise. Control measures start from the very time when you say there is an outbreak. The moment you identify there is an outbreak, with the given knowledge, if you know it is a diarrheal disease, you will start identifying what could be the reasons. Water, it is water contamination or food contamination. You already start working on treating the patients and controlling the outbreak by hygiene and sanitation measures, because we know that as a general science. But you simultaneously continue doing all these steps to go to the specific source, specific characteristics of this epidemic. And when both of these are simultaneously happening, and you know after hypothesis testing that what is causing the disease and what could be the probable way of controlling it, that you implement your control and preventive measures at a larger scale, right? And once you start controlling for it, you have to also establish a surveillance system. Surveillance system is very essential for any outbreak or epidemic investigation result. Once you have this done, I showed you, that outbreak can go into spread local transmission and can amplify. So just even if you start doing mass control measures, you need to measure simultaneously through surveillance how many cases are being detected. You listen to the news of COVID every day. How is that being notified? Because we have established a nationwide surveillance mechanism such that every positive case of COVID-19 is reported. And while we are doing a lot of containment and prevention measures, we are also simultaneously measuring what is the burden of the disease, what is the way it is growing. And should I do, what should I do, till when should I do, all will be informed by the surveillance, the results we get from the surveillance. So that's an essential part in management of epidemic. And last but not the least, very essential part is how to communicate it to different stakeholders, how to communicate it to the public, that they understand if this is a disease or symptoms they are getting, they should come to the health center, or what are the preventive measures they should take so that they do not get the disease, how to communicate it to the administration, the health system, how they should prepare themselves. Again, example of COVID-19. How should the health systems prepare themselves if the cases increase? Where would they keep the isolation for them for isolation or quarantine or planning for ventilators that would be required, right? So this is just an example of what info, how you communicate. So it depends on who is the stakeholder, what is relevant for that stakeholder, what is required out of that stakeholder to contribute in controlling of this epidemic at this stage. So these are the steps of epidemic investigation and response in the early stages of epidemic, whereas the last three continue till you actually control your spread and it comes down to, if possible, a very reduced transmission, that it is not a public health problem. Okay. Right. So as I said, that once you do an investigation, you get a lot of data and you try and understand what kind of outbreak it is. And I told you earlier that time, place, and person together define what kind of outbreak it is. So commonly, the epidemic can be broadly classified into four patterns: common source epidemic, propagated epidemic, mixed, and others. This is very important to understand. If you understand the way the disease is spreading, it will help you reach to the source. Also, it will help you to plan your control measures for the epidemic. So what happens? So if we, in our line listing, what we do is we identify every case who has come as positive and we see when this case became positive. So with time, you will see, you normally see this COVID graphs coming up everywhere with every day 18 cases or 20 cases or 30 cases increasing, right? So you are basically plotting the number of cases detected on that particular day. And if you keep plotting them across on the map, on the graph, you will see some kind of a pattern coming or the curve coming. So that is called epidemic curve, where you plot the number of cases on daily basis over a period of time. So just by plotting this curve, you can tell that what kind of epidemic it would be, what source it could be. For example, this curve, the left curve, you see the sudden increase in the number of cases and sudden decrease in the number of cases, right? Even in a small period of time. If you see such kind of a curve, then you understand that there must have been only one time exposure. It is one large peak and mostly within one incubation period. So that means some exposure may have happened. Maybe there was some festival function in the community. There was the vegetables they got were rotten. They may have had toxin in that vegetable, but because everybody ate from that festival celebration, they developed disease. And because incubation period varies, some people may show the disease in 2 days or 3 days, some may even show it in 20 days. But because it was just at the time of the function was over, there was no other exposure. So it was a common source, but it was a point exposure. In this kind of epidemic, you do not have to do much about controlling the exposure. What you have to do more is to treat the patients. And you will see that the epidemic or outbreak will automatically die on its own. Then on the right side, there is another kind of a curve. Here you see that the curve is such that it is a prolonged curve. There is a slow peak that comes and it comes to slowly comes down. And this kind of curve usually occurs, and if it is in beyond the incubation period, it usually occurs when you have a continuous exposure happening. It's possible there is a well which is contaminated and people continue drinking water from that well without realizing that the diarrhea is spreading from that well, right? So they'll slowly, the number of cases will increase and it will stay because the exposure is there, the risk is there, and people are getting exposed to it without doing any control measures. If you start doing any control measures, you will see that the outbreak will slowly then stop reducing. Right? So this is one kind of exposure. Here you have to aggressively act, aggressively identify where that common source of exposure is. And if you can control that common source of exposure, the good thing is this outbreak and epidemic is also easy to control because it is coming just from common source. It is not spreading from person to person. The challenge comes is in the next kind of epidemic, where what is happening is that 1 or 2 people got the disease from somewhere. Those 2 people spread it to another 4-5 people. Another 4-5 people spread it to another 10-12 people, and it slowly increases. This kind of a epidemic curve is called a propagated propagated epidemic. So here what you see is initially there are less number of cases, but slowly you start some peaks coming. Then these peaks, the size of this will keep increasing. Why I'm saying so? As I said, 2 people will infect another 4 or 5 people. But the time duration between them would be of an incubation period. It may take 3-4 days for those 4-5 people to come and reflect the disease. Then now these 4-5 people within a given incubation period of time will infect another 10-12 people. That will be your second peak, third peak. So propagated epidemics, they show this kind of a pattern. If the disease is very infectious, right, you would not see different peaks. It may feel like that it is a continuous common exposure epidemic. It is also possible. It is confusing. But if you study it along with the disease characteristics, you will be able to differentiate if it is a common source epidemic or if it is a propagated epidemic. COVID-19 is a classical example of propagated epidemic where one person is infected, another two is infected, another 4, and it is exponentially increasing. Right? Mixed epidemic is when the epidemic might have started as a common source epidemic, but there was a function, a lot of people from outside came, they got infected, then they went back to their own villages, and from there they started spreading it into their own villages also. So a common source then became a propagated kind of epidemic. So that's kind of a mixed curve can also be seen. So this is how we interpret just on the basis of time, that what kind of a curve it is, what kind of a source of infection it would be, how it is spreading, right? Now, how does place help us? I said time, place, and person. It is very important that as much as possible we try to plot it and see where the cases are coming from. This is a classic example from a cholera outbreak in London, and John Snow, who is known as the father of modern epidemiology, he was keen on understanding where this disease is spreading from, why it is spreading. It was all across London. So what he started to do was that he started to plot the cases, the houses from where the cases were coming. And this map is of a street, Bond Street area in London. There, the small dots, what you see are individual cases. And what you see in P is water pumps. This is at the time where we did not understand how cholera spreads. So imagine for a person at that time, it was kind of a disease which you do not understand completely. And to be able to understand, is it coming from food, air, or water itself was a challenge. But this thing helped him see that most of the cases are concentrated towards the center, whereas there are less number of cases towards the outside of this area. So one thing he really thought is definitely something is happening in the center of this area. Then they had hypothesis that either it could be due to water or food. He had no means of testing or controlling. What he did was he removed the water pump itself from that area, thinking that it could be the pump from which we are drinking water and we are repeatedly getting infections. The moment they removed the pump from that area, the number of cholera cases started to reduce. So that was his way of establishing association. He built a hypothesis and he tested his association, and he could say that it is because of water, and especially water from contaminated pump, that we are getting the spread of this outbreak or epidemic, and removing that source controlled the epidemic. So that is the kind of importance of maps. In today's time, we have gone far ahead, and like this is a map, recent map for India, where they have plotted where are the more number of cases coming from for COVID-19, so that we can do specific, region specific, controlled containment activities in those areas and protect the areas where we do not yet have the disease, right? So such kind of mapping can help you also identify what are the rates of disease in certain area, and why they are more in that area. Furthermore, it's just COVID-19, which doesn't yet seem to have any association with environmental factors. But imagine if it was malaria, you could be able to see that malaria may be spreading more in tribal areas or forest areas. I'm giving examples of diseases which we already know. Imagine a disease which we do not know about. In that scenario, it becomes very important to try and understand the characteristic of disease in any manner we can. And place, geography becomes an essential component in understanding of the disease. We can also club time and place, especially when it becomes a pandemic, right? So this is just an example of clubbing time and place. On January 20, it was just confined to China. Then by February 15, it spread to 28 countries. By March 1st, it spread to 66 countries. And by March 20, it has spread to 165 countries. So one reason why India could react so early to pandemic was because everybody, either due to IHR or media, or they were keeping a track on how the disease is spreading. The moment it started spreading across borders, even before WHO declared it as pandemic, our country was responsive enough and started to take mitigation actions, like they stopped flights coming from China, they started fever surveillance, or they started detection of cases at the airports, because still for us at early stage the airports were the area from where the cases were entering into the country. Right. So such kind of mapping in time and place together, and you see that it is spreading, makes you identify the threat early and respond to the threat early. This is another just an example of a Spanish flu where they saw how the infection spread. But this was post hoc. Later on, they saw just to understand how it spread across the world, what routes it took to develop more understanding of how disease spreads. Now, coming to a person, this is, I guess, much more than time and place which we have been talking about. So what do we have to look into? What we generally look at? We look at the person's characteristic in terms of age, gender, immunization. Have they received immunization for relevant to that disease in question? Do they have any comorbidity? Is there any behavior which is associated with the disease? Is there any occupation which is associated with the disease? Migration, genetics, right? Or any other component which is peculiar to this particular disease. This is important, and you can understand it from examples like polio. In polio outbreak, imagine if it were to be a new disease, and you see that this disease is just being noticed in children less than 5 years. So there is an age-related association, and I will contain and I'll do any control measures for a specific age group. Or is there any difference in terms of gender? Or is it there any difference in terms of immunization? People who have vaccination for polio do not develop the disease, who do not have developed the disease. Right? If I can see such kind of a pattern coming, then I will try to identify people who are more susceptible to infection or disease, comorbidity. Right? So these kind of behaviors, you can pick up each one of them, and each one of them can help you understand what kind of people are getting disease and what can I do to control it. This is interpreted on the right hand side, and I've colored this. So this is interpreted. You collect the information and then you interpret it in form of rates, age and gender specific infection rates, immunized, non-immunized, what is the rate in the two groups? Is the rate more in the migrants and the travelers? Is the infection rate more in certain occupation? Like for COVID-19, you will slowly see that it might be more amongst people who are migrants or health staff who are, if they do not have proper protection, because they are more at the risk of getting the infection, right? So this defining helps us understand where to focus our control. Infection is one thing. The other thing is disease rate. Why I put these as two different rates is that not everybody who gets infected may develop a disease. That's another thing which you must be hearing in the news, that there are a lot of asymptomatic cases of COVID-19 or infected by coronavirus, novel coronavirus. They may not have the disease, but they may still be spreading the infection. And death rates. Death rates may also differ. Like COVID-19, you know that the comorbidity, it's known that elderly and people who have any underlying disease are more prone to get the disease, more prone to death. So this is how we analyze and interpret our data from persons. At the earlier stage, it is about generating hypothesis and testing your hypothesis. At a later stage, it feeds into the strategies for containment. Who are susceptible, who are at high exposure or low exposure risk, who are non-susceptible. The people who are non-susceptible, they are the people who actually stop the infection from spreading. They contribute towards herd immunity. More non-susceptible people is always a good news. More susceptible people is always a bad news. Because the more the susceptible people in the population, more chances of their getting infection, more chances of the infection spreading out. Susceptibility, you can see on the right side, I've enumerated some factors dependent on certain things that the person may have immunity, either due to vaccination or some genetic healthy genes or just innate immunity as such in that population, right? Susceptibility also depends on the transmissibility of the agent, how quickly it spreads. The thing about COVID-19 is it is amongst the fastest spreading viruses. It may not be the deadly spreading disease, but it is amongst the fastest spreading viruses, and it is becoming difficult for us to contain the spread in first place. Forget about the treatment and management of the COVID disease. Right? Similarly, risk of disease also has certain factors which contribute. Will you get a disease or not? You'll be surprised that for polio, which is such a disease of concern, or which was such a disease of concern, only 1 in 1,000 infected child would develop a disease. Whereas in smallpox, more than 80% who got infected would develop a disease, right? In COVID-19, 40 to 50% may not develop a disease at all, and another 40-50% may just present as mild case. So if you develop a disease or not after infection is another factor which we need to understand while we plan our containment and control measures, right? And who are at risk of death? Why are we so scared about COVID-19? Because one thing is getting infection, the other thing is it is causing death. Who are the people who are getting who are vulnerable to this death? Can we do something about it? Can we prevent them? Or what more we need to do in terms of treatment to reduce the deaths as low as possible? So this evidence helps you into containing of your controlling of your epidemics.
Dr. Samiksha,
Yeah.
I think I see people are asking what time it will conclude, because
Okay.
we have committed till
I
4 o'clock.
okay. Right.
So we'll send them the slide, and there are a couple of questions also. So see
I
when you
will
want to conclude,
will
and then we'll come to the some questions to be answered. And there are some people I see who raised the hand. Maria Das, Nirmala Rani, and Manohar Reddy.
right.
Will allow them to speak to the group also,
Right.
right?
Sure. Definitely. Give me 10 minutes because I
Sure,
guess we
please.
started, by the time I started, it was a little late. So I want to finish the science part of it, which is there, and the knowledge about COVID-19 I'm already giving simultaneously. So I'll quickly skip on
Please
those
go
slides.
ahead. People are
Yeah,
liking it.
sure.
They are asking the slides also. We'll share to them.
Yeah, sure.
Please go ahead to conclude that
Right.
at the right place.
Right. Sure. Thank you. So now we have talked about in terms of time, place, and person, which is among the host. But once you identify what is causing that disease, it is also important to understand what kind of agent it is. Is it a new virus or new bacteria? Is it a re-emerging bacteria, or is it a mutated form of bacteria or virus? How it is being transmitted? Is it direct or indirect, through aerosol, through blood, through vectors? Like COVID-19 is through droplets. A person who has infection through cough, sneezing, they're spreading it, and then the virus stays on the surface. So that surface becomes a vector, and if you touch the commonly touched surfaces which may have been touched by an infected case, you may also acquire that infection on your hand and then onto your body, onto your face. So you need to understand how this spreads. Does the viral load have a role to play into the transmission? What are the factors which contribute to faster transmission or a slower transmission, right? So I've already given these examples. Herd immunity I'm highlighted. It's something which reduces the ease of transmission. If most of your population is not susceptible to the disease, that means infection, that means they will not have infection, so they will serve as a barrier for between the two case susceptible cases, right? So the concept of herd immunity will be talked about in subsequent seminars also. But just understand, if you have more number of people who cannot get infection, they kind of become a barrier between a possible case and a susceptible person. And if they come in between, the infection will not pass through them. So that is what herd immunity is called. A herd immunity at a certain level, if 60% or 70% of your population cannot get infection, then the transmission rates really go down. We are hoping that in COVID-19 also we acquire this herd immunity quickly. The other factors which contribute to the rates which we have talked about is the virulence of the agent. If do we have any preventive measures, hygiene and sanitation, specific protection, which can help us control this epidemic and to treat the complications and the infection. Just two slides on quickly on the control measures, what we do about epidemic. Once we understand all of this simultaneously, and as we understand more, the commonly known measures for control are early detection and containment. In that phase, isolate. The moment you know this area has a lot of cases coming in, geographically freeze your borders, isolate that cluster zone, and then at an individual level, detect the cases early. You don't have to wait for the lab investigation. Even based on the syndromic investigation, isolate the possible cases. We have created a definition. Who are our suspect cases? Isolate them. Who do not have the disease yet, but may have disease and they will fit in the criteria of suspects, quarantine them. Close contacts, quarantine. So basically, the idea is to control and contain those people who have the disease, who may have the disease, and who have potential to spread it to other population. Surveillance, we already talked about. Active surveillance, case and contact tracing. Actively go in search of possible contacts and stop them and contain them before they become diseased and before they even spread it further. That is active surveillance. Passive surveillance, look at what kind of cases are coming into your hospitals. So that will give you an idea of how the disease is spreading. And sentinel surveillance we do to understand in-depth characteristics of the disease, which will help us in planning our containments as we go ahead. The more knowledge comes, the more and better you plan. And you take the response based on what evidence surveillance is generating or other science is generating. Then in the next phase, I've already talked about it in control and mitigation. The best you can just do is try to control the spread further, try to control the mortality, try to control or have mitigation measures for economic, political, and social systems. Because health is one aspect, but the other aspects which get affected also contribute to bad outcomes in a community level. Elimination eradication, we talked about, that comes at a very later stage when you see the transmission has already reduced to very less. Now, few slides specifically on COVID-19. Before I go there, maybe we'll just, okay, let's just finish this and we'll go to the poll and take the questions quickly. I'll not read the slide, but I just want to present here that how the pandemic has behaved so far with all the concepts which we have talked about till now. So as said that we have to develop a definition. That's what WHO has also developed, a definition of suspects who have to be identified early and quarantined or isolated. Probable cases where you should start the treatment straight away. Confirmed cases that they are confirmed by laboratory investigations. You do give them treatment anyways, what has to be required. But for the confirmed case, then you start doing contact tracing, right? That's what COVID-19 in which we are doing. So that's the role of the definitions. So once we have the definitions, we also plot in terms of time. So you see these kind of graphs every day. This is a simple concept of epidemic where you plot against time, try to understand how the cases are increasing or decreasing over a period of time, how long I should continue these measures, if my control measures are working or not. Right? So simple graph can show you how the things are moving. This is the latest. The first case came on 17th April, and by 20th April, you see this is how the pandemic has spread. This is to show the place distribution as of 20th April for COVID-19. Clearly, it affects the whole world. India, we have already talked about. Then in terms of person, what we talk about, what a number of cases, number of deaths, how many active, how many recovered, total number of cases in per million population. These are the characteristics of persons in numbers you see, but the characteristics which in COVID-19 are of importance are which age group has mortality. So 60 plus age group has higher mortality. So if you do that kind of a investigation into your epidemic, then only you get to know such kind of information. Then only you take control measures that elderly should not come out of their home. They have also seen that male have higher death rates compared to females, and the mortality is also associated with any underlying disease. If people have underlying disease, they are more prone for, they have high death rates. So now, as a country, we can take steps what to do. China has had high death rate overall. Italy had very high death rate overall. But one of the reasons was they had older populations. Whereas in India, we have an elderly population of around 8%, which is, I guess, one third of Italy. So it's possible that in India, we may not see as high death rates, right? So the demographic of the population also will play a role in the mortality rates, we may see in India in times to come. How the infection spreads, we know, all of us know that it's mainly through droplet infection, but the virus stays on the surfaces and for prolonged hours. From there, through hand and through other equipment, it can spread further. Uh, I'll just want to give you a concept of reproductive rate. So when you see this curve, and why we are panicking about COVID-19 is that it is very quickly spreading. And how do we measure that quickness of spread? It is through the reproductive rate. So it is between 1.5 to 3.5 for COVID-19. What that means is that every one person is infecting another 1.5 people, or one person is infecting another 3.5 people. In India, it is around 2.25 right now. Imagine after with such a lockdown measure. If we do not have that lockdown, it can spread very fast. And the factors which contribute the spread of it is, as we have talked about, the transmissibility, what is the density, how closely we come in contact with each other, what is the infectiousness of the disease, right? And what is the proportion of susceptible or immune in the population? Unfortunately, we have almost all of our population susceptible to this infection. Till now, we haven't found any data which says that we have immunity towards this virus, or we have genetic immunity towards this virus. As of now, every individual is equally susceptible to get that disease. That's why it makes it even a more dangerous disease. So as a epidemic has 4 phases, COVID also has 4 phases of epidemic or now pandemic, where you have early detection, local transmission, then community transmission, and then it spreads, amplifies to larger population. Same principle, based on same principle, we have defined different stages. WHO has defined a containment strategy understanding on the understanding of what disease is. Again, simple, coming from your science. Stop human to human transmission. Isolate people as early as possible. Reduce the transmission from animal resource if there is any evidence of that transmission, right? Treat the clinical severe cases to reduce deaths. Find ways of having new diagnostic techniques, new therapies, new vaccines, because as of now, we do not have any of these things for this virus, right? Communicate the risk. People who are at high risk, they should be in self-isolation or self-quarantine. And try at the same time that we do not have too much of social and economic impact. This is the broad strategies. And what we are trying to do is we are trying to flatten the curve. See, understand that our health system's capacity is at stake. The way the disease is spreading so fast, it's reproducing so fast, it may not be as fatal as many other diseases. It is not as fatal as other diseases we have known in the past. But because it is spreading so fast, we have more number of cases coming at the same time, and we may not be able to treat them. Even if we have treatment, we may not be able to treat them because our health system's capacity is limited. That's the reason why we want to slow down this epidemic till we find a solution of dealing with this epidemic. So that's what the approach is with all the science we understand so far about COVID-19. And the public health measures which are being taken off, you already know of. Early detection, isolation, either at home or for mild cases or at hospital, using PPE. Once the cases are coming to the hospitals can become hotspots. Infection can spread from there. So hospital, you can isolate them, but at the same time, there the nurse and the staff and the doctors should use proper PPE equipment, personal protection equipment, so that they do not get it, they do not get a disease, and prone to deaths, and they further do not spread it to other people in their families or in the hospital. Contact tracing, we know, we talked about it. Detect them as early as possible. People who do not have disease but are close contacts, they can be quarantined. Hand hygiene and infection prevention, social distancing. Social distancing and hand hygiene mainly to reduce transmissibility as much as possible. We have to reduce the reproductivity of this spread of infection, right? And then community containment measures. If you see certain areas from where the more number of cases are coming, I showed you graph of India, you can do much more containment measures in that area so that not people do not move in and out of those areas. And at a national level, which has not done as much previously, is in the past history, but is being tried in this epidemic, is subnational and large lockdowns. So this is what the measures are being taken. And I just conclude, this is the end of the presentation here with a lot of questions. We are still at the stage of trying to control the speed in which it is spreading. At the same time, provide treatment who are getting real sick. But we do not currently have good preventive measures. And one thing which depend on is vaccine as soon as it comes, and if we can do mass immunization of the population to get over this pandemic. Other thing is herd immunity. There's no evidence as such for herd immunity yet, but what we are hoping that probably slowly people who get infected, they will not develop the disease again. They will become from susceptible to they will become non-susceptible, and the more number of such non-susceptibles will increase in the population. We will acquire some herd immunity, and the transmission will reduce. What will happen post lockdown? Again, I guess next presentations will cover all these things in details. I'll stop here and open to the questions.
Dr. Samiksha, just forgot the time also actually.
Yes.
Marvelous, virtual kind of applause for a wonderful presentation. Thank you, Dr. Samiksha, for an enlightening presentation on the right way to understand the outbreaks, epidemics, and pandemics. I am sure the basics, what you have given, and linking them to epidemics, pandemics, and also specific examples, what you have taken. Definitely, it is going to help the participants of this particular webinar to better appreciate the role of epidemiology, and also to better understand how to deal with such pandemics, epidemics, and outbreaks. And you have talked about the epidemiological investigation, which most of us as clinicians are not really much aware of. I am sure the process you have given will enable most of the clinicians and also the administrators who participated in large number today would be able to make a lot of sense of it. And I'm sure it is going to act as a tool in their daily work. And you also have talked about the curves and the reproductive rate. These are the concepts, and these are the definitions which in our daily life, in a hurry, probably we have forgotten what we have learned in the medical school. And thank you very much for refreshing all those terminologies, and also adding the recent developments which have happened on that front. I also thank all the participants for their patience, and also very enthusiastic participation. I see a lot of questions are already being posed. I see some of them are really restless to pose their questions. I would open actually the session for questions in a bit. Probably I would like to request an answer to one of my questions, if it is okay with you.
Sure.
In the capacity of chairing this session, let me take the opportunity to ask this question. As we
Sure.
know, in the current pandemic, I
Right.
am talking about the COVID-19. The lot of various the concepts have come into the public, which we see in the press. One of them is public health emergency of international concern, right? We all know that it had been talked about in the media, and it had been really been discussed by all the people other than the healthcare professionals.
Right.
In the outbreaks, epidemics, and pandemics, where does it stand? What is the significance of it? That is a number one question. Number two question probably is a lot of people had been criticizing World Health Organization for their delay in both declaring PHEIC and also the pandemic, right?
Right.
Uh, why does it happen? Why does actually WHO, what would be the process? Why did they take time? Is the criticism right or wrong?
Right. Okay. The first one, see, for something to be called as public health emergency, there are two things which are important. One, it is a thing of mass. It has a big quantity to it. It can influence large populations, right? So that's of concern. And the other thing, it is sudden in nature and it requires sudden intervention to it, right? So that's why in the given scenario, even when uh, we at this stage with the anticipation, when we know the way it spreads, it's an exponential spread of the virus. So in this COVID-19 scenario, epidemic, which may coming from different parts of the world, it calls for a public health emergency because we understand the rate by which it is growing, and we also know we do not have much measures of dealing with it if it increases by that rate. So yes, it is a public health emergency to be specifically dealt and quickly dealt. The question on WHO, why it declared it late? See, as a scientist or as an epidemiologist, I can't comment uh, as such on the political scenario or other things. All I can say is that a lot of things go into understanding and declaring and defining it, and even declaring it requires a different kind of political and bureaucratic process uh, to say and call it a pandemic. It might have taken its course, but at the same time, what you need to realize is that the data was available, the information was available, the epidemic was spreading, the pandemic was spreading across countries. You do not need to wait in this era of science and information. You do not need to wait for someone to declare it pandemic when you can clearly see that your borders are not safe and it is coming towards you, right? So WHO delayed it or not is a question I wouldn't like to answer, but I would like to definitely say that if countries did not respond to that early, it was their fault. It was not WHO's fault.
Thank you, Dr. Samiksha. That's a wonderful, very diplomatic epidemiologist answer. I'm sure, we will not go into the politics. Um, I think, let us open actually the session for the questions from the audience. Mr. Pranav, I think, you have the list
We
of
have
questions.
5 people in line. One by one, we are just activating their audio. I
Okay.
will just announce the I think sequence so that people can be prepared to ask the questions in a very precise manner or make a comment. The sequence is Maria Dash, Nirmala Rani, Manohar Reddy, Ramesh Abdul Razak, and finally Dr. Dipankar Kundu. So I'm on one by one. I'm just activating each one of you. Uh, so I request Ramdas and to just close down your microphone, or because there has to be only 4 person in the room.
Okay.
Then only we can allow. I think some of us need to go out of the room, out of four. I'm getting comments from the next speaker, Professor Shamana. Shamana is writing a very good one. So compliment to Dr. Samiksha from your next speaker. He has just written in the comments box here.
Thank you.
So,
Thank
so
you.
I'm just accepted. Yeah, you can go ahead ask questions from the audience.
Uh,
From the, I'm waiting from the audience.
okay.
I allowed them to ask questions. Dr. Manohar Reddy, Dr. Dipankar Kundu, Dr. Anil Kumar, Dr. Ramesh Abdul Razak, all of you have been activated to ask question. Just see the microphone icon at the top and then you can speak to the group. Meantime, if they are, by the time they are setting up, let me put some questions which is already asked in the chat box.
Right.
And some of the questions you have already responded actually. So I
Right.
will not repeat those questions. So Dr. Madhulika Banerjee, she asks that which test is better, oropharyngeal or nasopharyngeal test?
Okay. See, that's a way of taking a specimen, right? And then what test you are doing it is the PCR test. So, oropharyngeal, going towards the pharynx, behind the pharynx, is better. It has better detection of the virus. Whereas in that also bronchoalveolar lavage, there are all other kind of specimens which are much better than oropharyngeal.
Dr. Madhulika have another question here. She's asking that is there any possibility that a low grade fever can cause COVID-19?
Well, COVID-19 causes fever, not fever causes
That's
COVID-19.
right.
But yes, so see, COVID-19, the way the disease pattern is, not many population level studies have happened. So we do not have clear understanding what proportion will get the disease, what will get mild disease, or moderate and severe. But whatever evidence has been generated so far, it is possible that uh, out of 100 infected cases, 40% may not develop any kind of symptoms, right? And another 40% or 45% may just develop mild symptoms which may last a day or two or 6 or 7 days or 8 or 9 days, which includes fever and cough and cold. Consistently, whatever cases have been detected, fever is something which is common in more than 95%. So it is possible that someone may just present as low grade fever, may have COVID infection, right? But as per the definition, what WHO proposes is fever and any of the ARI symptoms is then when we call it as a suspect of COVID-19 case. So with the given knowledge and given evidence, we should go by this definition: fever, low grade fever or high grade fever doesn't matter. Fever along with any symptoms of ARI, respiratory infection, should be classified as a disease.
I think Dr. Maria is not able to join the live call over the audio. Let me take her questions to you. She's asking that we got COVID-19 from the bat, from where the bat got, whether by eating fruits or any insect.
Okay, see, the evidence says that coronavirus normally occurs in these animals. And there are a lot of, even in humans, like influenza virus, which is not that virulent, which we have got used to, it commonly occurs. So bats generally may have had this kind of a virus. The more question is that this strain of virus, how did bats got this strain of virus, which spreads so fast, and we got it from bat to the humans, and then it is spreading into the humans. Okay, so that question can be answer. Either it is a virus which has already been there, got mutated, converted into a new form of virus, which has such infection rate that it could infect humans and spread into humans. That's the best hypothesis I can give. There are a lot of theories coming around which claim things it was well, I won't even learn to list those theories unless those are proven, right?
We'll take maybe 4 5 questions more. Mr. Pranav, if you can actually segregate those questions which are more related to the concepts and understandings of epidemiology, that would be better, because on the further presentations, four more presentations are there where the clinical aspects and other aspects can be covered. So let us not hurry. Uh, for Let us go into the questions which is directly related to this particular topic of the day.
I think most of the question I see is has a COVID-19 impact.
Mhm.
We have following speakers to cover more on that.
Absolutely.
And we have already exceeded time by more than 50%.
Yeah.
Mm,
Maybe you can actually, couple of questions, which are already being sorted. So if you could actually pose them to Dr. Samiksha, and then with that, probably we can close this session, and then uh, we will go for the next one.
yeah, before closing, I'm not sure whether the people who requested to enter in the audio call room, whether they could activate the audio. Dr. Kundu, I don't think they are able to speak to us.
Mhm.
Anyway, so I think uh, let's conclude then that we'll address the questions maybe in the next webinar. We give them these questions, selected questions to the next speaker to cover it as part of the presentation as well. I just got Dr. Vinil asking, Madam, I have a doubt. Since this seems to be spread from bats, there are plenty of animal viruses awaiting to create a pandemic. So why don't we isolate all the viruses from each animal and start testing for the virus beforehand? Interesting question. Would you like to respond?
Right. As you yourself said, there are so many that you won't even be able to count them. So what all can you test for? It's difficult. But at the same time, uh, there's zoonotic disease experts, they are virologists who tend to do some kind of a sentinel surveillance or regular testing of these viruses, which goes on. But the nature of viruses is such that they can mutate at any time, especially for H influenza kind of viruses and coronaviruses. Uh, the mutation rate, as seen in the past, is quite rapid, and so we cannot be really prepared for what new kind of a agent will come to us, and we do not have resources, and it's not practically feasible to keep track of every virus in the animals. That's not feasible. We will have to rather find ways of reducing this. What do you say? The transmission. Can we do something about that? If it is in animals, it doesn't cross over to humans. Can we look at those strategies, preventive strategies? That's what something we can really look at. Or we can look at better preparedness. That moment we see any such outbreak, we should have more aggressive means of controlling it before it even becomes an epidemic. Forget about the pandemic. So these are the two things which are more practical and we should really focus on.
Good. I think 224 people eventually could join this conversation. We saw some of the people could not join because of some error, some technical things response coming to them that they are not able to join that. So maybe next time we see all 300 plus who registered can join. So I think thank you very much, Dr. Samiksha for a lovely presentation and very elaborate thing.
Right.
We'll share the video recording as well as slide to all the people who have registered here.
Sure.
Dr. Ranga, would you like to make a final comment before closing this session?
Thank you very much, Dr. Samiksha, and also the participants, and also the other collaborators, Indian Institute of Public Health, University of Hyderabad, and Sanmed Healthcare. Thank you very much. And I'm sure the next presentations or the next sessions, which are 4 in number, they are going to be equally interesting. And I'm sure, by end of the 5 lecture series, I am sure if not, we are going to be specialized epidemiologists, but we will be able to very well appreciate all the concepts of epidemiology and also how to make use of them in our practice as infection preventionists and as clinicians. Thank you very much and have a good day. Stay
Thank,
home wherever it is possible and whomever it is possible, and stay safe. Thank you.
thank you, everyone. Thank you for the opportunity.
Thank you. We are closing the.
Okay. Thank you.